A 45 years old right-hand dominant woman present with wrist pain that is present when she does activities of daily living while at home. She spends a significant amount of time in her garden when she notices increased wrist pain, especially when she uses her thumb. She reports that these symptoms do not improve with rest. She denies any history of trauma to her wrist and has not been diagnosed as rheumatoid arthritis. You move on to examine the patient. You notice pain and swelling localized over the region of radial styloid. The pain radiates down the thumb and thickened fibrous sheath is palpable over the radial styloid. Maximum tenderness is noted over the radial styloid. And tenderness also noticed along the long abductor tendon and muscle. Pain is increased when extension and abduction of the thumb against resistance. A Finkelstein test is positive, produce significant pain. You move on to do radiograph for the patient and P and lateral wrist joint as an important hyperpronate view or Robert view is done, which is under normal limits. No CMC arthritis is evident on the Robert view. A differential diagnosis of radial styloid region pain can be scaphoid fracture arthritis, flexor carpi radialis tenosynovitis, thumb carpometacarpal arthritis, intersection syndrome, or Wartenberg syndrome. In our case, the diagnosis was de quervain tenosynovitis. De quervain disease may be caused by any condition that produces swelling or thickening of the tendon of the first dorsal compartment of the wrist. It is stenosing tenosynovitis of abductor pollicis longus and extensor pollicis brevis tendon. This typically occurs in the third and fourth decade of life and is 10 times more common in women. The cause is usually related to overuse and may be associated with rheumatoid arthritis. Overuse causes a chronic inflammation of the sheath that covers the long abductor and short extensor tendons. The tendon of the abductor pollicis longus and extensor pollicis brevis passed through the fibro-osseous tunnel found by a groove in the radial styloid and overlying extensor retinaculum. The tendon deviates as they pass through the tunnel, and the angle increases with ulnar deviation of the wrist. Anatomical studies of fibro-osseous canal has documented that 94% of specific abductor pollicis tendon has 2 to 4 slips. Multiple extensor pollicis brevis tendon are found only in 2% of the patients. Multiple subcompartments are recorded in 47% of patients. Multiple abductor pollicis longus tendon slips and 2 subcompartments are the rule rather than the exception in the normal anatomy. Despite the fact that many anatomical still suggest that the tendon of extensor pollicis brevis and abductor pollicis longus are contained in a single compartment under the extensor retinaculum, several anatomical studies and surgical studies have convincingly demonstrated that this is true in less than 25% of the patients. So accordingly, one should be certain to identify the extensor pollicis brevis and abductor pollicis longus tendon at the time of operation. Negative radiographs and clinical examination determine conservative management, starting with custom thumb spica splint. In addition, anti-inflammatory medication and corticosteroid injections can be given in the first dorsal compartment. They are mostly successful within the first 6 weeks after the injury. Some have reported even a higher success rate, although a series of 2 injections may be necessary. Harvey et al. Reported that the injection of steroids and local anesthesia and tendon sheath relief was seen in 80% of the cases. However, when pain persists, surgical intervention is recommended. Regarding the surgical intervention, the first dorsal compartment is exposed to a skin incision that runs dorsal to the volar in the transverse to oblique fashion, parallel with the skin creases over the area of the tenderness. Dissection is continued through the dermis, avoiding branches of the superficial radial nerve. A longitudinal incision is made through the entire length of the dorsal compartment. Carpal ligament exposes the tendon in the first dorsal compartment, with the thumb abducted and the wrist flexed. The abductor pollicis longus and extensor pollicis brevis tendons are carefully lifted off the compartment. Be sure there is no additional tendons in the separate sheath. In this case, a short extensor tendon of the thumb did not, if not lie together with the long abductor tendons, then a separate incision is indicated. The compartments are opened and the fibrous partitions between the two compartments is also excised. One of the functions of fibrous reticulum covering the first extensor compartment is to prevent anterior displacement of the abductor pollicis longus and extensor pollicis brevis tendon during palmar flexion of the wrist. This function should be preserved by dividing the reticulum near its dorsal line of attachment with the radius, thus preserving the ligament as a sling. Frequently, the abductor pollicis longus and extensor pollicis brevis can be located within separate spaces formed by the intercompartmental septum in the first compartment. Both tendons may also be duplicated, therefore the first compartment may contain 3 or even 4 tendons in some people. Thus, it is important at the time of release to make sure that any intercompartmental septums are divided. The surgeon should not assume that he has released the tendon and complete release has been obtained when he observes 2 tendons are exposed. The skin is closed and a small pressure dressing is applied. The dressing is removed at 48 hours and a patch dressing is applied, and a motion of the thumb and the hand is encouraged and increased as tolerated. To avoid complication, careful attention to the surgical technique is essential. A common complication due to surgical technique is superficial radial nerve injury. Other complications include tendinous adhesions, which can cause neuritis, limit tendons and wrist function, and volar tendon subluxation. Persistence of symptoms is also possible. If repeat corticosteroid injection fails to relieve symptoms, surgical exploration may be necessary.